Good morning, Dr. Kalra.
Good morning, Manali.
It is an honor to welcome our keynote speaker, Dr. Gurpreeth Singh Kalra, who is the Medical Director of our Fertility Clinic in India. Dr. Kalra has developed his career in women's health and reproductive medicine over the last 30 years, working in Europe and the UK. He is also an honorary academic lecturer at the Bristol Medical School at the University of Bristol. And the most important thing, he is a visionary and a strategic clinical leader with commitment in patient safety and the improvement in the healthcare. Medical education expert, Dr. Kalra will be educating us today on the topic of technology and the future of fertility treatment. Thank you so much, Dr. Kalra, for giving your valuable time to us and to present and to give us this talk on the Indian Fertility Show. Now over to you, Dr. Kalra.
Thank you, Manali. Thanks for your kind words. My pleasure to be here. I will start by sharing my presentation first and take it from there, okay? So yes, as I said, it's my pleasure to be here today. The technology has had a very close relationship with medical treatments of medicine forever. In any field of medicine, technology plays an important role, largely in diagnostics, all the imaging you have to do, the analysis of blood, for blood tests, pathology, histology, technologies used, even medication for radiotherapy, a number of things. And similarly, in fertility management, technology has always been very closely working with the scientists and the doctors, and has influenced fertility treatments positively. But that changed where technology and science moved to next level with success of IVF. So I'll make a start. I think the journey of how technology has influenced fertility treatment. We had first successful IVF treatment. Now, in 1978, in Oldham General Hospital in Manchester, United Kingdom, Louise Brown was born, this lovely lady in the middle of this image, who's now 43 years old. Is that when the world had the first successful IVF baby. Now, this outcome has enormous consequences, and we had interestingly, Louise Brown was with us around the World IVF Day, 25th of July, which is her birthday, and around 1 week before that, and around that time, our fertility clinics in India had Louise Brown. We did several webinars, and I had an opportunity to speak to her during one such webinar, and I said to her, for the want of better words, but Louise, imagine, I just can't fathom the fact that you were not meant to be here if it wasn't for IVF. And imagine babies that have been born in this world from IVF, successful IVF treatments. And all those parents who've been given the joy, the bliss, the fulfillment of having a family and having children. And I think it is very difficult for people to understand, apart from those who are unwillingly childless. It's a big trauma and very difficult situation for them. So IVF led to possibility of those people who are not able to have children to have their own families. So Louise Brown, born on 25th of July 1978, after 10 years of hard work between Sir Bob Edwards, Patrick Steptoe and Jean Purdy, led to this miracle happening. And this story has to include the legacy and the success of IVF in India. Officially, the first successful IVF in India happened on 6th, or the birth for successful IVF happened on 6th August 1986, which was about 8 years after Louise Brown baby Harsha was born in India. But with time, it is increasingly being recognized that potentially the first successful IVF in India was baby Durga. Baby Durga born on 3rd October 1978 in Hazaribagh. Dr. Subhas Mukhopadhyay, who was working in the team with Sunit Mukherjee, cryobiologist, and Dr. Saroj Kanti Bhattacharya, the gynecologist. It wasn't recognized officially at the time. They did not publish their paper for some reason or didn't present their results, and therefore it remained a little bit unknown. And I know now that the first successful IVF in India, even on the new art bill currently tabled in Parliament of India, is baby Durga. Then the successful IVF baby is baby Durga. So baby Harsha was officially for many years, and now there is the possibility that actually was baby Durga, and that makes India to have the credit for having the second successful live birth after IVF treatment. Not only that, baby Durga was a frozen embryo transfer. So that makes India the first country in the world, potentially, if that is true, to the first country in the world to have successful birth after IVF and from a frozen embryo transfer. And Dr. T.C. Anand Kumar, who was responsible for baby Harsha's success, along with Dr. Indra Hinduja in Mumbai, has himself written a paper, I think in 1991, where he recognized that the credit should go to Dr. Subhas Mukhopadhyay. So that's the legacy of IVF success and of fertility we have in India. And that takes me to the frozen embryo transfer technology and the freezing of eggs technology called cryopreservation, which then started happening following the first successful IVF birth. So officially, the first live birth from a frozen embryo transfer is recorded to be 1984. But if it is true that baby Durga was the first successful IVF in India, and she was from FET, frozen embryo transfer, then the credit of having world's first frozen embryo transfer goes to India. And subsequently, gradually we started being able to freeze the eggs and then have successful live birth in 1986. So earlier on, the freezing technology was slow freezing. And then later on, it has moved on to become fast freezing called vitrification. The difference is that fast freezing gives more stable state of these cells, the embryo or the egg, and leads to better outcomes for our patients. Now I have to go a little bit back and take a step back and explain a little bit to our audience here what we are actually talking about and what are the fundamentals of IVF. It is important to understand if you have to build up on that around the technology in IVF. So in natural conceptions as well as in IVF, the basic process is that there's an egg cell which is there, and there are sperms. And the sperm has to fertilize the egg to become an embryo. So embryo is basically fertilized egg, which over a period of time divides once put into the in the right medium first. After the fertilization happens, the embryo splits, the fertilized egg splits into 2 cells, and then 4 cells, and 8 cells, and then grows in over 3 to 5 days to become an embryo, which is day 5. And this can be done between day 3 to 5 generally, most often be transferred back into the womb of the mother, and hopefully become a baby. Now, I also like to mention here that different elements of technological intervention in IVF treatments has increased the success rate, as well as understanding of the science of IVF altogether has contributed to success rates significantly increasing over the last 30 odd years. The live birth rate recorded in 1991 in the United Kingdom, from based on HFEA data, was only 9% live birth rate. So 9 out of 100 treatments succeeded. So the chance of success was really 1 in 10. And in 2018 data, the live birth rate was 31%. So a 3 times nearly increase, more than 3 times increase in success rate. So coming back to cryopreservation, it has significant consequences, and it made it possible for certain groups of patients to benefit from it, particularly women who unfortunately end up having malignant conditions, for example, cancer. Cryopreservation technology made it possible for those women to preserve fertility. Not only those women, women who are having conditions, genetic conditions, who are at more risk of losing their eggs quickly. Also men going through cancer treatments, losing sperms, because most cancer treatments, either chemotherapy or radiotherapy, will eventually lead to damage to eggs or sperms, and therefore they do not generally have the possibility of becoming parents. But if they're able to preserve fertility early on, before the treatment starts, we are giving them a chance of having family later on. Now, it is important because lots of studies have been done on this, and there is good evidence suggesting that individuals going through cancer treatments, if they've been given the opportunity to preserve fertility, they have better well-being when they survive and come back, and the later life, their better well-being and the quality of life is better. So that is, generally an extremely important development where these individuals now have a chance of having family. Moving on to genetic testing, this technology also played an important part in making life of our citizens or patients who need fertility treatments better, the experience better mainly, as well as there is evidence that it may be improving success rate in certain groups of patients. Now, what happens is that it is possible now to pluck one cell out of these embryos. This is micro manipulation at cellular level, at that degree it goes. So technology makes it possible, and there's our experienced embryologists can do this procedure. They can go into these embryos with very fine instruments under very powerful microscopes and take one cell out, which is analyzed in genetic labs. And we can really find out, screen these cells for a number of genetic abnormalities. And what it does is, it can help those women, for example, who have genetic conditions running in the families, so that they can have IVF, make the embryos, screen the embryos, and put back only those embryos which do not carry the disease. And imagine the benefit of breaking that cycle of knowing that my baby, I know, is not going to have that disease which has been running in my family. That's one thing. The other thing is, women with advancing age tend to have increasing risk of genetic abnormalities in the eggs and in the embryos. For example, there is good evidence suggesting that women at the age of 39 to 40, if we do IVF on them and we examine all their embryos genetically, 4 out of 5 embryos potentially can have genetic abnormalities. And imagine now, if we did not have the possibility of genetic testing, we put back one embryo which is abnormal. And what this leads to is either a miscarriage, early miscarriage, late miscarriage, late pregnancy loss, stillbirth. It can lead to neonatal death, the baby born but abnormal, unhealthy, with lots of abnormalities congenitally, genetically, functionally, and rarely these babies can grow up to live a very difficult life of poor quality. And all these situations are traumatic, painful, difficult experiences for parents. And what we can do now with genetic testing is that we can avoid that heartache and that pain. So what traditionally without this technology happens more in women with advanced maternal age is that you put one embryo back, they miscarry, put another one back, they miscarry, you put another one back, and all this can be avoided. We can test the embryos, put back only the healthy embryo, and they don't have to go through all the miscarriages. The time to success is brought closer, and lots of heartache is avoided. So genetic testing has significant advantages. Now, there are some limitations, side effects like every treatment. Sometimes genetic lab will come back with the result, because it's only one cell we're analyzing. After all, technology can have its limitations, and it will come back and say the result being indeterminate. We don't know whether this embryo is likely to be healthy or unhealthy. Also, some embryos have 2 cell lines. They can have a line of healthy cells and a line of unhealthy cells. Now, depending on which cell you pick by chance, you might think this embryo is healthy, put it back, and it might turn out that at birth, this embryo has some problems, or other way around. Also, this is an invasive technique. When we are plucking the cell out of the embryo, we are increasing the risk of losing the embryo. The risk is very small, but some embryos can get damaged and die out. So we can lose some embryos. That takes me to 1992, where another significant development happened in treatments of IVF, which changed really the face of treatments available for male infertility. Now, as a background, we know that either purely or in combination with female factors, male infertility can contribute to problems in 50% of couples. And in 1992, they say it was by accident, but although accident, there's a lot of hard work and science goes into these things. Gian Piero Palermo at the Université of Brussels, along with his colleague, head of department, Dr. Paul Devroy, developed a technique whereby we can have fertilization of the egg happening with only one sperm. Now, I have to give a bit of background to that to our citizens and our patients, that normally in IVF, when we are putting the egg and the sperms together for them to fertilize, we need at least 50 to 100,000 sperms per egg. So we need a lot of sperms present in the ejaculate. And we put them together, and 50 to 100,000 sperms around each egg, try to fertilize it. And then one of those sperms manages to penetrate into the shell of the egg, get into the cytoplasm of the egg, and fertilize the chromosomes in the egg with the chromosomes in the sperm head. And Gian Piero, what he did was, in those men where there was very few sperms present, because it would normally not fertilize the egg, they managed to only need one sperm. So they would cut the tail of the sperm. Again, micro manipulation at cellular level. They were able to put one sperm head, inject it into the egg. The fertilization happened. And as we know now, since there are more IVF treatments done these days with ICSI than with the treatment with intracytoplasmic sperm injection with this modality than with just plain IVF. And as I said, this made it possible for those men who had low sperm count, poor quality sperm, or sperm not motile enough, and therefore it will not fertilize the egg, to have biologically own children. I must also add here that this is probably one of the very few treatments where a woman carries the burden of a condition that man has. So on a lighter note, guys, all those men whose partners together have had treatment with them, you should be very thankful to them. I move on from here to our next technological advancement. Remember, I talked about in 2 slides before about cryopreservation making fertility preservation possible. That was the main group of our patients who benefit from cryopreservation, that they can preserve their fertility. Apart from those who have IVF and have supernumerary or extra embryos, they can save those embryos and come back later on to have more babies. But this technology of ovarian tissue cryopreservation transplantation made it possible for very young girls. Now we know that IVF cannot be done on very young girls before puberty because their eggs never grow to a size where we can collect the eggs by doing IVF treatment. So there was really no possibility for these young girls up to the age of 13, 14 years where we couldn't do IVF, and they were to be in this very unfortunate situation of having diagnosis of cancer. How could we preserve their fertility? But what happened over the years with a successful live birth from this technology happening first in 2004, brought about by Dr. Jacques Genet in Belgium. So what we now have is that these girls, we can take one of their ovaries out quickly, and it doesn't take much time. They can go on to their treatment quickly after that. We need only a day-case procedure, and most of the eggs are present in the shell, in the outer layer of the ovaries, and we can take this shell off and make it into little squares of 1 centimeter square each, and these squares of the tissue can be frozen in a suitable medium, and this tissue can be kept for very long until this child, and usually the survival rate for these cancers is very high, and about 90%. And these girls will generally survive. They will grow up to become women. They will want to have their families, and then they can come back and at least have a chance, And the success rate is improving every day as the technology is advancing. So this tissue can then be thawed and put back into the pelvis of these women. Different places have been tried, including under the skin of the arm, etc., etc. But now the more accepted way of doing it is that we take a whole ovary out, shell out the top layer, make little pieces, put them in the right medium, freeze the tissue, keep it for long. These girls come back. Unless they've had a radiotherapy of the area of the womb, their womb will be healthy. We can put these back, and as we can stimulate them, and some of the women also have natural birth. This tissue becomes alive, develops a blood supply, and starts releasing eggs. And some of them have natural pregnancies, but most of them need IVF, where we will stimulate them just like an IVF with hormones, and they will produce eggs. We can take the eggs out, take the sperm of the partner, make the embryos, put them back, and give them a chance of having family. And as I earlier said, there's good evidence that quality of life is much better, well-being is much better of these patients if they've had the opportunity to preserve their fertility. A second group of patients who can benefit from this technology is women who are diagnosed with cancer at all ages, and their oncologist tells them that your cancer is at a stage where we cannot wait. We need to start treatment as soon as possible. Because an IVF treatment needs 2 to 3 weeks to get the eggs, we don't want to rescue your cancer advancing. So in that case, again, all we need, a gynecologist needs, is a half a day. You can take them to theater with general anesthetic, do a laparoscopy, take an ovary out, and send them to their treatment. And that ovary can then be dealt with in the same way. The tissue can be frozen for them to come back and to survive. And by 2018 already, we had 87 live births from this technology. This technology is only just recently, we're not talking about very, very present and a bit of future here, but this technology has just moved on from being experimental to a mainstay treatment. It is now being used in a lot of Western countries. And I know that there are a number of centers in India offering this treatment, that we can preserve not only eggs or a sperm or embryos, we can now preserve ovarian tissue and auto-transplant it to give these very young girl or women with cancer a chance to have their own baby. So moving on to another technology that is changing the way fertility treatments are done. And this treatment, this modality is actually been around since 1990s, but is ever advancing and is well going to be there and well into future, is getting better and better. Now, this is called Timelapse Imaging technology, which helps us in embryo selection. So again, explaining a little bit of background. Traditionally, when we do IVF, it is the embryologist who will have put the embryos or the egg and the sperm into an incubator for them to fertilize. We'll take the dish out after 24 hours to check for fertilization. Then they will put them back, take them out again after 24 or 48 hours, check them for the growth of the embryo. And this snapshot of what they look at after 24, 48, 72 hours gives them some information. And looking at how the embryos look at that time, the morphokinetics, scientifically talking, the way they look like and the way they have grown and developed is a snapshot in time, and they get some idea, and they grade these embryos and tell us whether this is a good embryo or bad embryo. They grade the several grades, they can grade them too, and we can then, and the science is not full good, the science is kind of 50-50, but we've used that traditionally and has something to say and gives us some idea of the quality of embryos. Now, time-lapse imaging came about 20 odd years, 15 years ago, where a camera is put into these incubators on top of every dish where embryo is growing. And it takes a picture of the embryo every 5 to 15 minutes. And these images then put together over hours and days can give us hundreds of thousands of images, just like the movies used to be played in the past. When you run these images one after the other fast, you can see really a video kind of a thing of these embryos growing over time, and you can get a lot more information. So when you're looking at these only between 1 to 24 hours and then 48 hours and only a snapshot, you're missing all the information what is happening in between. And there can be things happening in between these times that we missed, and we could have used that information. And I can talk a lot more scientifically about it, but that's not the remit of this talk. This remit is to explain it in an easy, understandable way for our citizens. Now, that made grading of the embryos much more sophisticated. However, it also reduced the exposure of embryos to change in environment, going in and out of the incubator, change in temperature, change in pH, and that exposes these embryos to risk. And by putting them in the incubator where they can stay for all those 3 to 5 days, and we can just externally monitor them, was a big win. And therefore, this is a very stable environment. This paper from European Society of Human Reproduction and Embryology from 2020 summed up everything about time-lapse imaging and gave us 11 recommendations. And probably the top one out of that is that time-lapse technology probably offers the safest and most stable embryo culture environment. Continued embryo monitoring has allowed us to identify previously unknown or undetectable aspects of development, which can have bearing on the quality and outcome of this embryo. Now, this technology is still, we still cannot say that it 100% improves the success rate. It probably does, but that is becoming, that expectation of having better success rate by using this technology is becoming better and better by adding other futuristic modalities to it, which we will talk about, for example, artificial intelligence, non-invasive analytical approaches, which I'll talk also about in a minute. And, there is a promise that the time-lapse technology is likely to evolve into a full-blown embryo selection modality in a non-invasive way. So we may not then need to do that many embryo biopsies for genetic testing. We may be able to say, and there is already some platforms suggesting that they can tell us up to 80% probability of predictive value that this embryo may be abnormal. Not the detailed genetic analysis, but a broad idea whether that is the normal embryo or abnormal embryo. And that takes me to the role of artificial intelligence. Now, artificial intelligence is ubiquitous around us nowadays, as you will know. It is everywhere around us, and it is sneaking into our life like nothing before. Imagine your Siri, the Alexa, the Cortanas, they're artificial intelligence. They are using lots of algorithms and giving you information and guiding your life. So much so that online shopping has these algorithms, artificial intelligence algorithms. You open up your shopping portal, it'll show you the things you've wanted to buy, or you've been surfing around and looking at, and it'll give you a whole range of those things from those suppliers. In other words, who've given these search engine optimization companies, for example, Google, more money to show you those things so you can sell those things, and then they pay more money for search engine optimization. And all those things are happening. They're influencing our behavior, our shopping patterns, or even our voting patterns. Lately, there have been stories that this technology, by putting in algorithms to your Facebook use, if you are in the middle and don't know which way to vote, they can influence your mind by selectively feeding you with information and news to sway you in one direction or the other. And also, to top it all, self-driving cars are coming. All these electric cars, Tesla is supposed to be inbuilt with a self-driving technology. So this technology is around us and is becoming a part of us. And this technology has also made its way into assisted conception treatments or fertility management, and is making its way in big way, and is likely to become a permanent part of it. Hopefully, it seems like it is going to improve the outcomes as well as experience of our patients going through fertility treatments. Now, currently it is being used or being developed in a way of using time-lapse technology, imaging technology for embryo and sperm selection. So the definition of artificial intelligence is something made or produced by human beings rather than occurring naturally. So this intelligence is made by him. That's a whole different story. I recently read a book by Stuart Russell about the human compatibility with artificial intelligence. Very interesting. There's so much around it these days. The field of medicine, however, the backside is the field of medicine risks a disingenuous, a sneaky, a negative, a unknowingly loss of human element, that being the patient and doctor relationship. So what is happening is that more and more automation is coming in assisted conception. There is a risk, not a risk, it can be a blessing, but there is a possibility that the labs are going to get automated. And because within the embryology labs, more precise, intense jobs are happening, and they're quite monotonous jobs. They're very suitable for artificial intelligence and machine learning, and that might be taken over by machines. Equally, decision-making, clinical decision-making, when you feed millions and millions of decisions into a machine, it becomes more intelligent, more specific, more precise, and more learned than human beings and human mind, and they can give us more clearer answers. So the risk will be that we might lose an element of patient-doctor relationship, the human element of it. And it will come in sneakily as artificial intelligence come in other parts of life. Now, I talked about the analytical ways of grading the embryo. This is another way of doing it, which is future. It's still experimental, just like artificial intelligence in these labs and in the embryo grading. The biosensors, the use of bioelectronics, these minute microcellular level sensors. Now, this study published in this journal is actually from the unit where I've worked in the last many years, Wales Fertility Institute and Swansea University. This team has managed to, in collaboration with the scientists from Spain, developed those micro sensors which were put in the fluid where the medium where the embryos are growing, and leave them there. And these sensors measure level of certain hormones. In this case, they measured tuberous necrosis factor alpha, interleukin 8, and beta HCG. Now that's a bit of scientific stuff, but in simple terms, they monitored these hormone levels over time and then analyzed the performance of these embryos, where they found different levels of these hormones and behaviors. And they found out that certain hormones, if they were high, those embryos did poorer than the others. And that is absolutely vital information, a non-invasive way of grading those embryos. And if that is added to time-lapse imaging with artificial intelligence, that might become the future of perfect embryo grading. I don't think we will lose genetic testing, because we need to specifically sometimes find out about a certain genetic condition or rule it out. So genetic testing in detail will be required, but who knows, we may be able to do it in a non-invasive way in future. So that so far is the journey of role of technology from past, present, into the future. And the last few things I've talked about are more experimental, but starting to step on the mainstay like artificial intelligence. I hope I've managed to give the limitation of time, I managed to give a good overview of technology in assisted conception of fertility treatments. And I'll be very happy to take any questions if there are any. And I'll leave you with that. Thank you again. Thanks very much.
Thank you, Dr. Kalra.